This is case study number 4. Quinn. Quinn is a 87-year-old white Caucasian male with a diagnosis of dementia. His past medical history includes congestive heart failure, hypertension, depression, and gout. His prior level of function consists of setup with meals and dependent in all ADLs since he arrived at the facility and is non-ambulatory. His social interactions consist of speaking only if spoken to or if he needs something, uses simple sentences, answers incorrectly when asked simple questions, recognizes his wife but sometimes confuses his daughters and grandchildren, smiles when he sees someone he recognizes. His family support. He has a strong bond with his wife Dorothea. And has 2 children and 5 grandchildren that all live within 2 hours of Dorothea and Quinn. They visit monthly. His living situation. He's been a resident at the nursing home for the past 2 years at Riverside Place, resides on the long-term care wing, and plan is that he will remain at the nursing home indefinitely. As far as his goals goes, Quinn is unable to set goals for OT and does not understand the purpose of OT. His caregiver, his wife, has a goal for him to eat in the dining room at meals. As far as the evaluation goes, we are going to focus on the analysis of occupational performance. So far, his feeding consists of a regular diet, requires setup for meals, is unable to identify and locate various utensils, has difficulty scooping food, can hold cup but only after it is placed in his hands, can only drink half the liquid because he cannot extend his neck from a flex position. As far as his cognition, he has short-term and long-term deficits that increase in executive function. He's able to follow simple one-step verbal commands accompanied by visual cues. He's unable to learn new information. His attention span is of 5 minutes. However, he is oriented to self and wife. As far as sensation, he is intact for both upper extremities. Since we said that he's non-ambulatory, he has a manual wheelchair. His position in the manual wheelchair is both legs are elevated and reclining back. He has a combination of Yale foam cushion. His back is reclined at 35 degrees angle. Quinn's pelvis is tilted posteriorly. Head is jutting forward. Cervical spine is in kyphotic posture. Also, his feet do not sit flat on the foot pedals when they are down in down position. When legs rested, they're elevated. His knees are bent approximately at 20 degrees. As far as his range of motion, manual muscle testing, he has an active range of motion within the normal limits for his upper extremity. Slightly less flexion of shoulders secondary to the kyphosis. His strength is of 4- out of 5. As far as his motor skills go, he has motor skills gross motor control with functional limits. And so far his fine motor coordination is impaired.
Okay, so now we're looking at occupations, and the question is, although feeding is the occupation that Quinn was referred for, do you think working on this skill might translate into other occupations? If so, which ones and why? And working on feeding with Quinn may translate to other occupations such as personal hygiene, grooming, dressing, and bathing. And when working with Quinn on eating, we will be addressing cognitive components as well as fine motor control. And these client factors and performance skills may translate to the other areas of occupation listed because they too require similar skills for completion. The next question was, describe a single intervention session with Quinn focusing on increasing independence at meals. So we said for 10 minutes, have Quinn practice picking up the fork and knife when cued to do so. The fork and knife could be labeled in order to help him distinguish. And then for 20 minutes, have Quinn use the fork to stab soft food items and bring it to his mouth. 15 minutes, have him practice scooping up ice cream with a spoon and bringing it to his mouth to eat. And this could be graded up or down in order to increase his skills. And then periodic rest breaks would most likely be needed due to his short attention span. And then we would also consider getting him adaptive eating utensils such as modified spoon, fork, as well as adaptive cup or plate. Okay, so now moving on to performance patterns. So first question to look at is, what impact do you think Quinn's inability to feed himself may have on his wife? And so we just said that seeing someone you love not be able to do something they have easily been able to do their whole life is most likely extremely hard for his wife. And so it's important as the OTs that we provide her with support groups and resources in order to help her cope. And then, how might his wife's roles and routines affect your intervention? Would you include her in any of your intervention sessions? And we thought that his wife's role would affect intervention because she does visit twice a week and he does recognize her, so she could be used in intervention to help keep him calm and relaxed, and that could be beneficial for the intervention session. But on the other hand, her routine of coming twice a week and taking him outside to read could interfere with therapy sessions depending on time, so that's something else that we would also have to consider. Okay, so now moving on to performance skills. Identify 10 key performance skills that have a negative impact on Quinn's ability to self-feed. So we said searches and locates. He cannot locate various utensils needed for his meal. Reaches. He does not reach out for the utensils. He requires them to be placed in his hand. Flows. He's not using smooth and fluid arm and wrist movements because he's unable to get food to his mouth without dropping. Chooses. He's unable to select the appropriate tools for the task of eating. Continues. He's unable to finish his drink without assistance. Coordinates. He fumbles with the spoon, resulting in spilled food. Organize. He requires setup for eating. He's not organizing his eating environment. Attends. Due to his 5-minute attention span, he's unable to attend to the entire task. Aligns. Due to his kyphosis, he cannot properly align for the task of drinking out of a cup. And heeds. He is unable to complete the task without help. And then identify 10 performance skills that are strength for his ability to self-feed. So grips, he's able to hold the fork and spoon correctly once it's placed in his hand. Lifts, he is able to lift the fork and spoon to his mouth. Handles, he is able to handle the utensils and piece of bread. Gathers, when he drops food into his lap, he's able to locate and pick it up. Endures, he's able to complete the task of eating without showing fatigue. Initiates, he's able to start the next step of using the fork once it is placed in his hand. Manipulates, he's able to use dexterous finger movements to get all the pieces of dropped food to his mouth. Coordinates, he's able to hold a cup and bring it to his mouth. Aligns, once given a straw, he is able to finish his drink. and uses. He uses the fork and spoon as intended once they are placed in his hand. So, what techniques might you use to facilitate the skills needed to improve his self-feeding abilities? And we said that adaptive utensils may be used to help with the skill of flows, and then have him practice identifying and reaching for utensils when cued to do so. And then proper positioning in his wheelchair may help with his ability to align. So then it asked us to make a list of all the possible complications Quinn might have because of his position in the wheelchair. So his posterior pelvic tilt is hindering functional activities such as feeding and self-care. He has internal rotation of the femurs and also rounded shoulders and back, which decreases shoulder flexion and prevents him from bringing food to his mouth. And then how would you modify Quinn's wheelchair to produce a better seated position? So because Quinn has kyphosis, he needs a different back for his chair to support him and put him at a 90-degree angle. He would also benefit from a seat cushion that prevents posterior pelvic tilt and includes a pommel to prevent internal rotation of his legs. And his footrest should be positioned at a lower angle as this is contributing to his posterior pelvic tilted position. So the next question is, you adjust Quinn's wheelchair so he sits upright at a 90-degree angle. He slowly begins to slip out of his chair. Explain what you would do in this situation. So it would prevent Quinn from slipping out of the chair and then have someone watch him while obtaining and placing Dyson on the wheelchair cushion to prevent him from slipping. So using figure 14-1, which was a picture of Quinn in his wheelchair, what is correct and incorrect with Quinn's wheelchair positioning? So incorrect was that he was positioned in a posterior pelvic tilt. His shoulders and back were rounded in a kyphotic position due to the angle of the chair, which should not be reclined at 35 degrees. And having his legs elevated and rested on the pedals is the correct idea, but it shouldn't be at a 20-degree angle. And that is it for that section.
Continuing with performance skills, this is a list of the possible complications that Quinn might have because of his position in the wheelchair. The first one is posterior pelvic tilting, which would hinder functional activities such as feeding and self-care. He would also have internal rotation of the femurs and rounded shoulders and back, which decreases shoulder flexion to bring food to mouth. And then 10 body functions that would have the greatest impact on Quinn's feeding skills are energy and appetite, joint mobility, joint stability, control of voluntary movement, attention, perception, experience of self and time, touch functions, visual functions, and orientation. So what can be done to improve Quinn's fine motor coordination? First, there's therapeutic exercise. So working with therapy, such as putting small objects in therapy and having him use his fingers to fish them out. And that would mimic picking up food to feed himself. And then a hand therapy ball to provide hand strengthening and finger strengthening and dexterity. And then there's also functional activities that he could do to help with his fine motor coordination, such as a fidget board, which is commonly used for patients with Alzheimer's disease. Putting together a puzzle could also be another activity, which would also work on his cognition. And also using a spoon to pick up beads, and this would kind of mimic the action of him feeding himself and scooping up those bits of food. And then lastly, using a fork to pierce pieces of Play-Doh. So since he has difficulty using his fork to stab his food, he could practice doing that with Play-Doh. The next question is, what strategies would you use for his cognitive deficits during feeding? So I would increase verbal cues to attend to the task, simplify the instructions, provide positive feedback,
review the names and function of utensils, and also do task segmentation. Moving on to context and environment. What type of environmental adaptations should be made to allow Quinn to feed himself more independently? We can adjust Quinn's wheelchair position to reduce his posterior pelvic tilt by changing the angle of his seat and lower his footrests and facilitate interior tilt that will facilitate feeding. What type of adaptive equipment might Finn need to enable him to be independent and self-feeding? Would you recommend adaptive equipment for someone with Alzheimer's disease? Why or why not? So recommendation of adaptive equipment would depend on the severity of the cognitive impairment. There are some patients with Alzheimer's disease who can become distressed with a break from routine or familiar objects. So I would try introducing a plate guard for Quinn to scoop up his food more easily and also reduce spillage. And then since he has trouble locating the utensils, I might also consider wrapping the handles in colorful tape or buying utensils with colorful handles that will help draw his attention to them. And then a utensil attached to a universal cuff on his hand will also encourage him to use the utensil rather than him keep putting it down. And then finally, a cup and a straw with a straw in the lid will encourage him to use that straw to drink, and since there's no way to drink from the cup without using the straw. How does food texture influence self-feeding? Do you think Quinn needs a change of texture? Food texture can influence the ease or difficulty of using utensils during self-feeding. Texture could also influence how motivated Quinn is to eat if he likes its sensory dislikes its sensory qualities. He doesn't seem to avoid certain foods, but since he does have difficulty stopping food with a fork and tends to drop a lot of food, we could try having him eat foods that are easier to scoop up, or he could also use his hands to pick up solid foods, such as bread. Explain how you would involve the dietary and nursing staff in your intervention. For dietary, I would ensure that Quinn is receiving the proper nutrition by providing him with a balanced diet. I would assess appetite changes, and as the disease progresses and appetite decreases, we would provide supplemental nutrition drinks, provide vitamins, assess texture tolerance, and simplify meals too by limiting distractions, providing just one or two foods at a time, and finger foods may also encourage independence rather than having him use utensils. With nursing staff, they should ensure carryover of interventions, and we can do that by educating them on processes. They should be helpful, but also promote as much independence as possible for Quinn. Some key things are hydration, so providing water throughout the day, consider medication changes when there is a change in appetite, give him plenty of time to finish his meals, and also be alert for signs of aspiration. What type of support do you think might benefit Dorothy as Quinn's condition progresses? To which other disciplines might you refer Dorothy? Identify resources in your community to support Dorothy. There are support groups for spouses with dementia. An activity that they could do is create a memory book with Quinn. And there's also support groups for spouses with chronic illness. There's also classes on communication and behavior education, caregiver group, safety education, and then some other disciplines that we might refer her to are social work and hospice services at the end of life. And then some community sources that we found are Alzheimer's Association, which provides local resources such as face-to-face education and a 24/7 hotline.
Okay, and now we're on to theory and evidence. And the first question is, what theories or frames of reference might you use in developing an intervention plan? And asked to describe the rationale for your choices. And one of the theories/frames of references that we thought would be appropriate in developing an intervention plan for Quinn is the person-environment occupational model. And our reasoning for this is that as Quinn's dementia progresses, it's important to find the optimal occupational performance which will mean constant evaluation and intervention at the person, environment, and occupation levels. And in Quinn's case, since his dementia is going to continue to progress and his symptoms will worsen, it is important for him that we use compensation and adaptation, not remediation. And the next question is, what, if any, evidence can you find to support your choice of theory and/or frames of reference? And there are several peer-reviewed research articles supporting the use of PEO in a case similar to Quinn's, and we have them listed on the screen right here. And one of the examples, I'll just read off one of the titles. The example is Applying the Person Environment Occupation Model to Improve Dementia Care. And the titles of all these are listed on the screen. And the next question is there evidence to support feeding intervention for individuals with dementia? And yes, there are quite a few. And feeding interventions for patients with dementia can increase their independence, and it allows them to make more decisions, speak more with their caregiver providers for options for their feeding, and if needed, they can receive a dysphagia diet, and they can gain more assistance from the staff. And a great example of this is that Quinn is in a long-term care facility, and he does require a lot of assistance from the staff at this moment, but with proper intervention, he may be at the point where he requires a little bit less assistance, which would overall increase his independence. And these interventions can definitely educate caregivers on the antecedents and consequences of feeding difficulties in those with dementia. And that information is from 2 different articles, which are listed on the screen right here. And the next topic we will be discussing is the intervention plan and goals for Quinn. And the first question is, identify the key issues affecting Quinn's ability to feed himself. And there are quite a few associated with his diagnosis of dementia, and these are some of the main key issues affecting his ability to feed himself, which includes memory issues, cognitive impairment, impaired fine motor coordination, cannot locate and identify his utensils, and he has difficulties extending his neck when he's drinking, so he can't drink all of the liquid that's in his cup, and difficulties scooping and piercing his food with a feeding utensil. And the next question asks to write out a problem list. And the problem list includes that he cannot feed himself without being handed food, so that increases the amount of assistance that he needs for feeding. And he does have short-term memory loss and long-term memory declining. And he has declining executive function. He has difficulties learning new information. He has difficulties feeding. He has difficulty locating and identifying utensils. He cannot scoop his own food, and he has difficulty piercing food with a fork. He drops food when using utensils. He has difficulty extending his neck to finish his drinks, as I mentioned in the previous question. And he requires one-step verbal instructions, which means that you can only give very, very simple instructions whenever working with him. And he has a dementia diagnosis. He has confusion, kyphosis, and impaired fine motor coordination. And the next question is to identify standardized assessments that would assist in the intervention planning for Quinn. And there are a few assessments that can definitely be used. And the first one can be the Functional Independence Measure, or the FIM, if it is used in the long-term care setting. And that would just get an overall picture of all of Quinn's ADLs and the amount of assistance that he requires. And then the next one is the Allen Cognitive Level Screen. And that one is used to determine the quality of problem solving that an individual uses when they're engaged in perceptual motor tasks. And there has been some research done on it about the use of the assessment with cognitive impairments. And then the next one could be the Functional Behavior Profile and the Contextual Memory Test. And there's a picture of it on the screen, and it requires the person to look at a picture, and then the picture will be taken away, and then they have to remember certain items, and then remembering if there was a theme. And then another one that's not listed on the screen that could be used with Quinn is the assessment of motor and process skills, or the AMPS, and that has been used with individuals who have dementia. And basically it measures the motor, which would be posture, mobility, strength, process skills such as attentional, organizational, and adaptive skills. And this requires task performance in ADLs. So that could be used to determine his performance in ADLs. And then another one that's not listed on the screen is called, and it's also from Pendretti, Chapter 35. And this one is called the Disability Assessment for Dementia. And it uses informant ratings, which would be an outside person, and it determines the abilities of an individual who has dementia to complete tasks in ADLs and IDLs. And it does provide some information on executive functioning. And the next question is, what short-term goals would you set for Quinn to help reach the long-term goal of eating in the main dining room? And based on the case study, it sounded like that in order to eat in the main dining room, you needed to require as little assistance as possible, such as maybe only setup. And in this case, some short-term goals that could be set for Quinn would be that he will locate and pick up his eating utensils, which will more than likely be adaptive eating utensils, with as little verbal cues as possible. And then another one could be that he will successfully pierce 3 out of 5 pieces of food with his adaptive eating utensil with moderate assistance. And then another one would be Quinn will bring 3 out of 5 pieces of food to his mouth using his adaptive eating utensil with minimal spilling would be ideal. And then lastly, another one that could potentially be used is that he will bring his adaptive cup to his mouth 3 out of 5 times with minimal spilling. And the next question is, what are strengths that could help Quinn achieve his wife and the staff's goals? And one important one is that he does have support from his wife, and he can follow one-step cues paired with visual cues. And he can hold a spoon and a fork once it's placed in his hand, and he can hold a cup when it's placed in his hand, and he is able to drink with a straw initially, and then from there on he does forget about it, but he at least can drink with a straw when it's presented to him. And then the next question is, what are deficits that may impede achievement of these identified goals? And as we mentioned earlier in the problem list, some things that may impede his achievement would be his impaired fine motor coordination, his short and long-term memory deficits, the fact that he does have a short attention span of only about 5 minutes, so that would require that there are quite a few rest breaks during intervention. He does have difficulties locating and identifying his utensils independently, and he does have difficulties piercing food with the utensil independently. And the next question asks to write a specific intervention plan for Quinn, which includes frequency and duration. And based off of Radomski, I believe, chapter 24 in our textbook, a method that has been used with people who have dementia or other cognitive impairments would be the task and or environmental modification training. And in this case, the task and the environment are modified to be simpler for the patient. And so in this case, the OT could set up a feeding session for Quinn and would have to work on showing him the order he needs to do things, and the order he needs to eat things on his plate. And then she would do one-step commands paired with visual and tactile cues, because that is what he responds to. And then something else that may help would be placing Quinn's plate in a specific order that would best facilitate independence. And then the OT could give one-step commands such as pick up your fork, pierce the food with your fork, bring the fork to your mouth. And that's just an example of an intervention for him. And for frequency, I wasn't exactly sure how many times an OT would see a patient in long-term care, but I would estimate about 3 to 5 times a week. And for 30 minutes, but something important to note with this is that since Quinn does have a short attention span, he will need to take quite a few breaks. And the next question is, who might be a primary payer for these services? How would you justify the payment? and Quinn is on Medicaid. And since Quinn is on Medicaid, I looked up some information online about it, and OT is recognized as a service covered under Medicaid, but it does say that it is optional instead of mandatory for states to include it in their programs. And something else that I found online is that Medicaid usually requires you to be unable to perform at least 2 of 6 ADLs independently, which is consistent with many long-term care insurance policies. And the ADLs listed were dressing, bathing, transferring, walking, feeding, and toileting. And Quinn is dependent on the staff for all of his ADLs. And in order to justify the payment, it would be really important for OT to justify the need for skilled OT services. And now we're going to move on to situational questions.
So the next section is situations. So the first question is, you have made changes in Quinn's mealtime routine and want other staff members to follow through with your interventions. Name all of the staff positions that would be involved and what instructions you would give them to ensure the desired program carryover occurs. So the people that we thought would need to be involved included nurses, nursing assistants, speech-language pathologists, physical therapists. And we would want to give them simple and concrete instructions to ensure that the carryover actually happened. And we would tell them if they were unsure of something or had questions to refer to the printed instructions given to them or to come ask the OT for clarification before proceeding. If this wasn't possible, I would want them to report back to me exactly what was done so that we could discuss it and prevent further problems in the future. The next question is, Quinn becomes agitated when you try to rearrange his plate to facilitate independence. He refuses to eat after you have intervened. What would you do? For that, we would ask him why he is upset by the way his food was arranged. Then we'd explain to him the reason it was to help him to eat more independently and improvise to find a way to arrange the food that will both appease Quinn and facilitate independence in feeding. The next question is, Dorothy decides to visit Quinn during the day at lunch. She wants him to sit on the patio with her. There is no table out there. What adaptations would you need to make to enable Quinn to eat his lunch on the patio with Dorothy? So for this, we would attach a lap tray that lays over the top of his wheelchair so he could engage in eating meals outside on the patio. Another option that we could look into is providing his food on a mobile rolling cart that will be rolled out to him on the patio. And I would also recommend that the OT make use of advocating mode in order to get a table on the patio for patients to engage in meals out there. The next question is, how would you deal with staff members enabling Quinn's dependence at meals? So we would teach them strategies on how to cue Quinn to feed himself. Therefore, he wouldn't use learned helplessness. So the same scenario occurs several days in a row. What might be some of the reasons as to why the nursing assistants keep feeding him day after day? So there could be a variety of reasons for this. Some that we came up with included, maybe the nursing assistants think that Quinn is taking too long to feed himself, so they want to speed up the process by feeding him. Or perhaps the nursing assistants believe that they should feed the elderly. Maybe it's a cultural thing. Another reason could be Quinn is unable to reach for utensils, making it difficult to feed himself. So therefore, they see that problem and think they should just step in and do it for him. And finally, another thing that could be coming into play in this situation is that Quinn makes too much of a mess when attempting to feed himself. So in order to keep the space clean, the nursing assistants intervene. The final question under situations is, you arrive at the facility early and go in to see how Quinn is doing with his breakfast. You see his nursing assistant feeding him oatmeal. What do you do? So in this case, you could explain to the nursing assistant that while Quinn does need some assistance with feeding, it is important for him to do as much of it on his own as possible. In addition, you could explain some strategies to use when feeding Quinn, such as using cues. Now we're moving on to the next section. This is the discharge section. The first question is, when you decide to discharge Quinn from OT services, what would you need to have in place to ensure he is able to maintain his current level of independence? And for that, we would want to make sure that he has the proper DME equipment and that he has 24/7 supervision and care. So we would need to ensure that Quinn's wife can demonstrate that she understands the caregiver education that she received from the OT while Quinn was still receiving services. Final question is, how could you monitor Quinn to see that he does not return to being fed at meals? And for this, we'd have to rely on caregiver reports and other nursing staff reports if he remains in the long-term care setting. All right, thank you for listening to our video.